This is Larry Greenwood, board member of the Japan Society. It's my pleasure to welcome you this evening this morning in Japan to our program about how Japan is addressing the coronavirus. But first, a few words about the Japan Society of Northern California. For the past 115 years, we built stronger connections between Japan and the Bay Area through programs and events like the one that we're hosting this evening. And we do it on a wide range of issues, including business and technology, government policies, culture, food, of course, sake. So please check out our website for upcoming programs. We do about one a week, so we have a lot of things to choose from. I'll just mention one this evening. We're hosting our 10th annual Japan-US Innovation Awards Symposium on July 14th and 21. This will be two different afternoons, the same program. Or same parts of the same program. It's a great way to keep up to date on innovation trends in the Valley and Japan and how the two are becoming increasingly connected. So please register for that program. Moving to the program this evening, Japan has had remarkable success in limiting deaths from COVID-19 without the draconian measures to shut down the economy that we've seen in China, Europe, and the United States, and also without extensive testing as we saw in Korea. So how did Japan achieve this remarkable success? And we have two great speakers this evening to answer that question. First, I'm delighted to welcome back, at least virtually welcome back, a good friend to the Bay Area, former Japanese Consul General Tomochika Uyama. Director General Uyama served here for 3 years until his return to Tokyo last year, and he's now in the Prime Minister's office as a Director General charged with handling trade issues and, as of a couple of weeks ago, working on the coronavirus response. The second speaker is Professor Hitoshi Oshitani, one of Japan's top virologists, who is a professor at the Tohoku Graduate School of Medicine and is a member of several government expert groups on coronavirus. He's also the co-author of a recent report from the Expert Committee on Japan's response, the Government Committee on Japan's response to the COVID-19, which takes an unflinching look at the response to explore what worked and what didn't work. We'll have time for questions after the presentation. As Kendra just said, if you want to submit a question in writing, use the chat function. You can start thinking of your questions now. If you prefer to ask a question orally, use the raise hand function. So without further ado, let me ask Director General Uyama to say a few words, and then we'll move to the presentation by Professor Oshitani and then to a Q&A. So Uyama-san, please, it's over to you. We're delighted you could spend time with us again.
Well, thank you, Larry, for your kind introduction. Good evening and good morning. We are in Tokyo at 9 a.m. on Saturday, June 13th. My name is Tomochika Uyama, Director General at the Office of COVID-19 Preparedness and Response, Cabinet Secretariat of the Japanese government. First of all, I'd like to thank Mr. Akiyama, President of Japan Society of Northern California, Mr. Larry Greenwood, former President and still the board member, and also Ms. Miho Greenberg, Kendra-san, and others for hosting this important event today. I'd also like to thank so many people, not just in San Francisco Bay Area, but also so many different places in the United States, Japan, and maybe other places. As some of you maybe know, I was serving as Consul General of Japan in San Francisco for 2 years until January this year. So I'm happy to be back here virtually via Zoom after my departure at the end of January. Or maybe I should say, welcome all of you to my office in Tokyo. I think you're Friday evening, and this time I'm sorry I can't serve you sake tonight, but I can serve you a great presentation by Professor Oshitani later. I'd like to really thank everyone who was so kind and supportive to me and my wife, and I was in San Francisco as Consul General. And also I'd like to apologize if I didn't have proper opportunity to say goodbye to some of you due to my time constraint. After coming back to Japan, I assumed the post at the Cabinet Secretariat in charge of trade negotiations for TPP, or Trans-Pacific Partnership Agreement. Our big boss is Mr. Nishimura Yasutoshi, a cabinet member in charge of many important areas such as TPP, economic and fiscal policy, and economic revitalization, among others. One of the important portfolio recently added to his already long list was preparedness and response to COVID-19. During the time of the state of emergency, I spent most of my time at home. That was the most valuable contribution to the society. I experienced telework for the first time in my life, which was not a bad experience. Around the middle of May, I was told, since Minister wishes to expand the function of public relations to overseas about the COVID-19 response, some of the TPP staff, including myself, will need to do that job while still keeping responsibility for the TPP. From around May 20, I started work on coronavirus. During the time of staying at home, I thought I learned a lot about this virus day by day, mostly through TV news and sometimes through Japan's famous Wide Show. But after my first opportunity to talk with Professor Oshitani, who is here with me today, I realized how little I knew about the virus. Since that time, I had a great opportunity to talk with our experts, including Professor Oshitani, for a number of times. And every time I feel that I didn't understand this virus as I do now. Late May was the time when the Japanese new cases of infections were going down. On May 21st, when I first met Professor Oshitani, the government of Japan lifted the state of emergency from Osaka, Hyogo, and Kyoto. At the time, only Hokkaido and also greater Tokyo area remained. On that day, I had my first press conference in front of foreign press correspondents. It was another fascinating experience because most of the press people were participating online. Questions came to me in writing through emails. One of the questions I received was, what is the reason why the number of deaths due to COVID-19 in Japan is so low compared with other developed countries? This was understood as the most important question from many Western media. And behind the media, there must be many people who wish to know the answer. The Japanese approach to COVID-19 was quite different from many other countries. The number of PCR tests was relatively low in Japan, so it gave an impression that many infection cases had been missed. While many other countries experienced strict lockdown, the Japanese government asked voluntary restraint. Japan is well known as super aging society. Tokyo and Osaka areas are well known as density of population and packed commuter trains. Many thought Tokyo is going to be like New York. I like New York, by the way. And the hospitals in Japan will be overwhelmed. So many cases with so many deaths. The result was different. While Japan did not do as good as our neighbors like Taiwan, we did suppress the deaths to a minimum, as Mr. Tedros, Director General of WHO, stated. Having said that, it is true that we lost many people. Shimura Ken, a famous comedy king of Japan, passed away. So was the famous Japanese actress Okae Kumiko. Mr. Okamoto Yukio also passed away. He was a great diplomat, a commentator, and a friendship builder, in particular between Japan and the United States. He must have been a good friend of many Americans like you. I could not believe his death because I met with Mr. Okamoto in March after I returned from the United States. Like many of you, I also felt scared to know how many valuable lives have been lost. And I also felt that I should do my best to facilitate the exchange of experiences of different countries, including those of Japan, for our future endeavor. On the first press conference on May 21st, I did my best to explain the strategy of Japan based on the advice of the Japanese experts. Since I thought an occasion would be necessary for the experts to explain to the foreign press directly, I asked the two leading experts, Dr. Omi Shigeru and Dr. Oshitani, to attend the press conference in front of foreign press correspondents, which took place on June 1st. That was a few days after the state of emergency was lifted nationwide. That was on May 25th. The essence of our message was that we should know the peculiar characteristics of the virus, and we should have a right strategy to tackle it. Through our early experience, the Japanese experts found that the COVID-19 virus transmits mainly through clusters or a super spreading event. So if such clusters were found and contained, the virus transmission will not be sustainable. Our experts also found the conditions where many clusters were created. They are closed space, crowded places, and close contact settings, especially involving loud talking or talking in close proximity to others. We call them the 3 C's, in Japanese, sanmitsu. In other words, if people can effectively avoid such 3 C's or sanmitsu, we will be able to prevent clusters, leading to slowing down the transmission of the virus. The advisory committee of the Japanese government, which is a group of experts, is headed by Dr. Shigeru, being a former WHO regional director for the Western Pacific region, as well as other positions. Dr. Omi has a long experience in WHO in many fields, including eradicating polio and addressing SARS. Dr. Oshitani Hitoshi, who is here today with us, is also a very famous expert and a member of the advisory committee as well, who also spent so many years in WHO, including in addressing SARS. From the early days, the Japanese government, including Prime Minister Abe and Minister Nishimura, attached great importance to the advice of those experts. We are lucky in that the top level experts in the world have been always with us for advice. During the last several weeks, since I started my work at COVID-19 office, I witnessed a number of occasions where our minister consulted with our experts. The experts gave important advice to the minister, and minister immediately gives instructions based on such advice. Actually, this is happening every day, not just during weekdays, but also weekends, including this afternoon. What I'd like to stress is that the Japanese policy is strictly science-driven, strictly experts-driven. So I'm very happy to invite Professor Oshitani Hitoshi. His views appear in Japanese newspapers and programs, as well as many international papers and magazines, including Financial Times, the Science Magazine, and many others. I understand, despite the great efforts of many excellent experts around the world, there are still so many matters we don't know about this virus. I hope today will be an opportunity to get to know the virus better and to learn from each other how to tackle it. Thank you very much, and I'd like to give the floor to Dr. Oshitani. Thank you.
Thank you, Mr. Uyama.
My name is Hitoshi Oshitani, and so I will share my presentation. Okay, so thank you very much for attending the important occasion, and it's my great pleasure and great honor to present our experience in Japan. And as Director General Uyama mentioned, we are using the quite different approach for COVID-19 from other countries. From the beginning, our main objective for the COVID-19 response in Japan has been to minimize the social and economic impact, while minimizing the transmission of this virus. And so far, we've been relatively successful in both in minimizing the social and economic impact and the health impact. I'm going to explain what we've been doing in the next 20 minutes or so. So the COVID-19 in Japan, and this is the general overview of the COVID-19 in Japan. There were two waves of outbreak. The first wave was triggered by imported cases from China. And the second wave was triggered by the imported cases from many different countries, including the US, European countries, Egypt, the Southeast Asian countries, and others. And the bottom graph showed the distribution of the countries, the original countries for the imported cases in Japan. And after the first wave was relatively small, but the second wave was much bigger because we have more imported cases. Actually, we had only 11 imported cases we have identified the 11 imported cases from China. Of course, there should be more the imported cases from China, but it's probably in job. And Japanese public's high standard of hygiene, willingness to comply with the government request and other cultural traits and lifestyle habits. But at the same time, there are two important factors which have not received due attention. These include early detection of transmission waves and our cluster-based approach. So we were able to detect the cases in early stage of outbreak. The first identified imported case from China was found on January 16. And the number of identified cases increased gradually. And by end of February, we managed to identify more than 200 cases. But in US and some European countries, the identification of the early cases were delayed. And that may be one of the important reasons to explain the difference between Japan and the US and the European countries. And we knew from the beginning that there are several important differences between COVID-19 and the SARS, the severe acute respiratory syndrome, which caused the global outbreak. And Dr. Omi and I were at the WHO Western Pacific Regional Office for this the SARS response. And for SARS, the majority of cases they had very severe symptoms, and including the death. But the COVID-19 is quite different. The COVID-19 also caused the very severe the viral pneumonia, and as you know, many people have died. But for COVID-19, there are also many mild cases and even asymptomatic cases, those without any symptoms. And this difference make the epidemiological pattern quite different. But there are also some common characteristics between COVID-19 and the SARS. The SARS was the spread mainly through the super spreading event. The only very few individuals infected many others. And most of these super spreading events occurred in the healthcare setting for SARS. But for COVID-19, also for COVID-19, the only small number of people infect many others. And the majority of the infected individuals, the nearly 80% of infected individuals, do not pass the virus to anybody else. So this is a quite important epidemiological characteristics of COVID-19. But the difference is for the COVID-19, the super spreading event or the large cluster of cases, mainly they occur both in healthcare setting and in the community. So that's the major difference between the COVID-19 and the SARS. And also for SARS, as I mentioned, the most of infected individuals that showed the very severe symptoms. So it was easy to identify the most of cases. So that's why we managed to trace all cases back to the original, the source, which was Guangdong province of China. But for COVID-19, because we have the many sources now, not only in China, but also the European countries, the North American countries, and so on. For Japan, we had the many imported cases from Southeast Asia and Egypt and some other countries. And also, as I mentioned, for COVID-19, there are many mild cases or even asymptomatic cases. There's still a lot of discussion that if the asymptomatic cases they have infectivity, which means the ability to infect others, but there's certainly mild cases can infect others. And milder cases are difficult to detect. So the virus, compared to SARS, is very difficult to identify. So there must be many the unidentified cases. And the unidentified cases can potentially cause large clusters or super spreading event. So, but for both COVID-19 and the SARS, the majority of people, infected people, do not pass the virus to others. So without clusters or the super spreading event, the transmission cannot be sustained. So it's a major difference from the infection like influenza. For influenza, the many infected individuals, they pass the virus to others. But for COVID-19, most of the transmission chains are actually dying off without any interventions. If there is no cluster, the transmission cannot be sustained. So our approach is the focusing the clusters. So, but to focus on clusters, we should be able to detect the clusters. So to identify the cluster, we have to do the different approach for contact tracing. In many other countries, including the US, you are mainly doing the so-called prospective contact tracing. You identify some cases. If you identify the cases, you identify the contact of the cases and follow the contact. But we are also doing this prospective contact tracing. But in addition to the prospective contact tracing, we are also doing retrospective tracing. to identify the source of infection. In many cases, that is cluster. The source of infection is cluster or the super spreading event. So that's one of the major differences between the Japanese approach and the other countries' approach. So by identifying the clusters, we can manage to interrupt the chain of clusters by the identified the infected, most of infected people in the clusters, and follow up those infected people within the cluster. And another advantage for the cluster approach is that we can identify common characteristics of the clusters. When this characteristic was found by Professor Nishiura of Hokkaido University, that he found that the most of the transmission was sustained by the cluster. And I discussed with the Hiroshi Nishiura that if we are just doing the cluster bustering, it's endless. So we should be able to minimize the creation of the clusters. To minimize the creation of cluster, we should identify the common characteristics of the cluster. And the Hiroshi Nishiura already had some data, and the data suggested that the closed environment is probably the one of the common characteristics of the clusters. And then we identified more clusters, and then crowded places and close contact. In the talking distance are the major characteristics for the most of clusters. Then we call this as a 3 Cs. Now even small kids in Japan knows about the 3 Cs. In Japanese it's sanmitsu. And so by identifying these common characteristics, we can send the more effective messages to general public to avoid such the risky environment. And so awareness about the 3 Cs is quite high in Japan, and the people are trying to avoid these risky environments. And we also did further analysis of clusters. We have already found more than 100 clusters, and the further analysis identified some additional risk factors, such as exercise, talking in loud voice, singing, and also the nightlife setting, while the people are talking in close proximity. So also the many large clusters that have been occurring in healthcare facilities and the nursing home, which result in many severe cases and deaths. In many hospitals, we have the elderly people. Most of the admitted patients are elderly people. And also another advantage of the cluster, the approach, is that we can find the early sign of the large outbreak or community spread of this virus. So this cluster approach can be utilized to monitor the situation. As long as cases are linked with the clusters, we can more or less manage that cluster. But the unlinked cases, meaning that the cases without link to any cluster, is the dangerous sign. If we have many unlinked cases, that means there might be the widespread community transmission. And we've been monitoring the situation closely. And again, the Professor Nishira's group did mathematical modeling to monitor the situation. And since the mid-March, the number of cases was increasing in Japan. And by end of March, we thought that the number of cases might be reaching to the limit of the hospital capacity, especially the intensive care capacity. The intensive care capacity is relatively low in Japan. And if the number of cases, severe cases, exceed that limit, we cannot save the lives. So that's why we advised the government to declare the state of emergency on April 7th. And compared with other countries, Japan has performed fewer PCR tests for the virus. And but we've been our testing strategy is focusing on high risk group, and especially the pneumonia cases, and also the people associated with the suspected clusters. And it was true that at the peak of outbreak, especially in early April, the timely testing was not always available for some locations, including the Tokyo, due to limited capacity. But despite such issues, Japan's testing infrastructure has been adequate for public health perspective to monitor the situation and to identify the most of severe cases. And also another important thing is we've been maintaining the quality of testing. We have a very good public health laboratory network. Each prefecture and most of the major cities have their own public health laboratories. And the quality assurance, the program is ongoing. Even before COVID-19, the outbreak, and the quality of the PCR testing was maintained in Japan. And so as Japan needs a restriction and seek to resume the social and economic activities, we are using the new approaches for the laboratory testing. And we are trying to identify the better testing strategy to identify the cases at the early stage, even the milder cases. And it is not easy, but we are trying to identify the best strategy for such testing. And so we also trying our best to the faster laboratory testing with shorter wait between the consultation and the test. And the time lag is getting shorter and shorter. And the point of care test, the rapid antigen test, and the point of care test are now available in Japan. And these tests might be useful especially in healthcare settings and nursing home the settings to minimize the outbreak in these settings, and also for early control of outbreak in these settings. And as a conclusion, the citizens' cooperation has been vital to showing the spread of the virus, while preventing the healthcare system from becoming overwhelmed. Focused cluster-based approach, and avoidance of the species helped control the spread of the COVID-19, especially in early stage of the outbreak. There's no time for complacency. We are still having some clusters in Tokyo and some other places. And the latent transmission chain still going on in some places in Japan. And maybe a new type of cluster could develop in the future. So the decline in number of new cases should be taken as an opportunity to prepare for the potential next wave, including a more effective, developing a more effective strategy in controlling the COVID-19. And Japan has learned a lot, and while there is still much to understand, that this is a new virus, new unknown virus, and there are many unknowns. And so we should share our experience with the world and participate in the global pandemic response. Thank you very much for your attention.
Great, thank you very much, Professor Oshitani, and also Director General Uyama. Let me take the prerogative of the moderator to ask the first question, and then we'll open it up and also read some of the questions from the chat that have been submitted in writing. My question has to do with technology. We're here in Silicon Valley, and as you know, we love our technology. For the tracing, in particular, the tracking of the clusters, the retroactive tracking, it sounds like Japan did it in a very kind of labor-intensive way, which is, with the use of Hokenjo in particular at the very local level, which is amazing. And I wish sometimes America had the same kind of interaction with its citizens at the local level that Japan does. I got a lot more attention in Japan when I lived there from the local government officials than I've ever had in America. but there's a lot of technology out there, and in particular, you have the Bluetooth enabled technologies to help track and trace contacts. You have Taiwan has used AI in its tracking and tracing. And so I'm wondering, how much technology was involved in Japan's efforts on the tracking side, and are you looking at making that more effective by the use of technology? And if you have any particular comments on the Google, Facebook technology, we're obviously interested in that as well.
We've been using some technologies. We also using the Google data, and particularly for retrospective or the contact tracing in general, we have not been using the new technology yet. In the public health center in Hokenjo, the public health nurses are mainly doing the contact tracing, and they've been working very, very hard and spending so much time to trace the contact. And it's, as you said, it's quite labor intensive activity, and we are now trying to implement some new technology to minimize the labor intensive activities, including mobile phone appli and some other the technologies. And so the database system is being devised now, and so far we have not been using the new technology so much. So it's now some trials are going on, and in near future the situation will be much better.
Just a quick follow-up on that, because obviously these apps are also getting a lot of attention around the world in terms of privacy issues. And China, of course, doesn't have those kinds of issues, but South Korea does. And I'm just wondering, is that an issue that you're concerned about, how to do the tracking with still maintaining individuals' privacy?
Privacy is important to know in Japan, and while doing more the effective contact tracing, we are trying to minimize the privacy violation, and so there are a lot of discussion now in Japan how to use these new technologies. And but so far we are not using the approach which have been used in other countries.
Larry-san, may I?
Please.
Just wish to tell you that as Dr. Oshitani said, using new technologies is we also think as a government very important, and the introduction of a new app is underway, and it's coming. I heard it's coming very soon. So that's the only thing. And this new apps Japanese government is going to employ is to have a great due consideration to the protection of the privacy. But that's coming very soon. Thank you.
Great. I don't see any raised hands. Oh, there's one raised hand. Let me ask, before getting to Michi, let me ask a question that someone has submitted in writing. The question is, in Asia, the death rate seems to be quite low compared to Europe and the United States, and not just in Japan, but Japan, South Korea, China, Taiwan, even Southeast Asia. If you look at the numbers, the per million death rates are all single digit all throughout Asia. So the question is, and yet the response has been different from different countries. And is there some kind of common thread, do you think, that results in this rather remarkable trend where it doesn't seem to be hitting Asia as much? And one question from Kenji Murakami in New York is in fact the nature of the virus somehow more virulent in the West than it is in Japan and Asia?
I don't think there is the major difference between the viruses circulating in Japan and other, or in Asia and other part of the world. But the reason why we are the much better in terms of number of cases and deaths in Asia, they should be they evaluate more closely. But the important difference is in general, in most of Asian countries, we were able to detect the early cases or early sign of transmissions. That's probably because in Asia, we've been having the SARS, avian influenza, and some other the major infectious disease, the outbreaks in the past decades. And the laboratory capacity, surveillance capacity, has been remarkably improved in past decades, especially after SARS in 2003. And actually, this was only possible by the support from US and some European countries. But thanks to this, the better capacity, in most of Asian countries, managed to identify the early sign of outbreaks. That's the possible reason. And also in Asia, we are using the different approaches. The Japanese approach is quite unique, but the Korea, the Taiwan, Singapore, and all of them are using the slightly or quite different approaches. And I don't think the one size fits all type of approach cannot work for this virus. This is a new virus, and the local station is different. Local capacity is different. So we have to adjust the approach or the strategy to fit the local situation. Over to you.
Great, thanks. And I think the audience heard Professor Oshitani mention it before. He worked for 7 years at the WHO regional office in Manila and knows the Southeast Asia and Asian region quite well. He's probably being also humble because I'm guessing that he had something to do with that buildup of capacity in Asia as well after the SARS. Let's go to Michi Kaifu for the next question. Michi is a board member of Japan Society of Northern California. Michi?
Hello? Hi. So can you hear me?
Yes, we can, and
Yes.
see.
Okay. I believe these findings and experience in Japan can be pretty beneficial information for all the other countries in the world. And so the doctors are writing English thesis to publicize it, and is government helping it? I know that doctors are so busy fighting the virus itself, but there are so many theses written in English all over the world, and I think Japan should publicize more in that sense. So how is it going in Japan right now?
Thank you very much for your the important question. We've been trying to publish some papers, and but some of them have been published, and we've been extremely busy with the response, and especially the epidemiological capacity in Japan. It's quite limited, and now we have more time, and we are focusing on the writing manuscript, and but at the same time, we've been sending the many manuscripts to the international journals, and many of them have been rejected, and so now it's probably the time to publish the more papers in the international journals.
Great, thanks for that. A question that Jack Mormon had, who is a good friend of the Japan Society here, is how do schools deal with avoiding the sanmitsu? It seems almost inevitable that they're going to be close in every respect. So how is Japan looking at opening or reopening the schools with regard to sanmitsu?
Now many schools are open, and they are trying their best to avoid the sanmitsu type of environment. And each school is different in terms of number of the kids, and also the local situation of the COVID-19 it's different between places, so they are using the different approaches. And again, the one size fits all type of approach cannot be the effective for this virus, and they are trying their best to avoid the transmission. But unfortunately, we've been seeing some cases, and if we cannot close school for years, so the early detection and early response in school setting is also the important.
Is there some kind of special measures that are being done to ensure that kind of early detection? Is it taking temperatures every day, testing? And also, did you actually faded out there? Are there cases of children coming down with COVID-19 in Japan?
There are some the clusters in schools recently, because schools had been closed for some time, and there were not many the school outbreaks, but now we are detecting some the clusters in school. Of course, the kids are wearing masks and avoid the close contact, and some other measures are being implemented. And we also trying to the temperature screening is also being done in some schools, but as a matter of fact, the most of the primary case, the source for the major clusters, did not have fever or very slight fever. The most of them actually do not have a cough or the apparent symptoms. But even without apparent symptom, they can probably, this is a very exceptional cases, but these are probably very exceptional cases. But there's some individual, they can pass the virus without showing the apparent symptoms. So the temperature screening may not be so effective to the interrupt or to avoid the school outbreak. But of course, the children and the teachers who are not well, they should not go to the school. So this kind of the rules should be maintained. Over to you.
Great, thanks. We have a question now from Ruth Muschel. Ruth?
Hi, I'm muted by you now.
Yes, you are now live.
Okay, thanks. As you know, identifying the people that are positive is the first step, and after that, you need to have some form of isolation or quarantine, and I'm wondering how that takes place in Japan.
Great question.
So all identified cases are isolated. Initially all cases were isolated in hospital, but now we are also using some hotels and some other the boarding facilities to isolate the cases.
And if that person had a job, will they be compensated for that time? And this is a big issue in the United States of people being identified as positive and asked to isolate, but then losing their jobs if they actually comply with that suggestion and not having the ability to have food delivered. And so I'm curious what kind of social structures are available.
That question, maybe I should answer the question. I think there's not a specific sort of compensation for this kind of isolation, but like other countries, Japan is also making a lot of efforts to help because this coronavirus crisis created a lot of economic crisis as well for many people. And there are a robust program from the government to help those people in need. But it's sort of different from those isolated cases in particular. Thank you.
Thanks.
Great, thanks. We have a question with regard to how the nature of the super spreaders. And so 20% of the infected are actually spread it. Is that based on, do you know what the factors are in going to making a super spreader? Is it physiological? Is it somehow that they're a great host for the virus and give it out easily because of their physical attributes, or is it social behavior, the people that just, social butterflies that interact with lots of people? Which is it, do we really know yet?
Actually, we don't know exactly, but actually only the very small portion of infected individual that can be a super spreader. The 80% of the infected individual that do not pass the virus to others, but the 10%, more than 10% of the infected individual that only infect the person. So they probably only few percent of the infected individual that pass the virus to many others. We are still analyzing the characteristics of these so-called super spreaders. But as I said, many of them did not have the severe symptoms or the apparent symptoms like a coughing or the high fever, and because of the milder symptoms, they were still active, going to gym or they're going to the karaoke and so on. And interestingly for the COVID-19, it seems that the infectivity, the infectivity means the ability to infect others, does not correlate to the severity of the disease. Even the milder the cases can spread the virus to many others. And so that's probably because some exceptional, the infected individual, they carry the virus in upper respiratory tract, in the throat, and they carry a lot of virus in upper respiratory tract. That's why some individual can infect many others. And the severe cases, they have a lot of virus deep in lung, in the lower respiratory tract. So that's why the probably severity does not correlate with the infectivity. And milder cases, especially those who are very active in doing many different activities, social activities, can spread many others. Over to you.
Interesting. Our next question is from Tomoko Ashino. Tomoko?
Okay. Thank you very much, Professor Oshitani, for wonderful presentation. So I'm Tomoko Hashino Otsuka in Kobe University. So I'm just wondering why COVID-19 is still prevalent in Tokyo area, but not in Osaka area. So this is my question.
I also want to know the answer. It's very difficult, but actually many imported cases that came to Tokyo. Mm-hmm. Number of imported cases was probably very different between Tokyo and Osaka. Mm-hmm. And right now in the Tokyo, we don't see any apparent the clusters, but probably the source of many sources of infections that are associated with the nightlife, bars, and so on. And we are discussing the Tokyo metropolitan government how to minimize the kind of transmission right now.
Okay, I hope so. Yeah, thank you very much.
Our next question comes from Narash. Narash, are you on?
Hi. So you can hear me, right?
We can now, yes.
Yeah, okay. So this is Naresh from One Concern. And my question is, I think I have two questions. So, this session has been very, I think, very informative and very, very helpful. So one question about the risk due to, transportation, like because of trains, like public transport in general. So how is that being accounted for and mitigated in the overall strategy? And the second is that there has been a lot of talk about, a second wave of, the virus attacking. And, I think that could be even more severe. We are hearing about that in news, every day. So what do you think about that, in terms of its severity and, I think the planning for it based on the experience that we had? Thank you.
Thank you very much for your question. Our congested commuter train is the world famous. And but the now telework is the promoted in Japan, and the congestion is much better now. But there's still many people are using the train. But there is the certain difference between the transportation setting and where the most of clusters that have been occurring in Japan. The most of clusters have been occurring in the sports gym, the nightlife, the club, the live music, the place, where people they congregated each other, and the talking and the singing, the shouting type of setting. But in general, in Japan, most of people are not talking in the train. And then nowadays, most people are just watching the smartphone. And there is the certain risk of transmission in such setting, but the risk is not that high compared to other the super spreading event, the setting in Japan. We managed to identify the one cluster in the transportation system, which was the very small cluster inside the aircraft. And there might be some unidentified transmission in the train, especially in the congested train. But I don't think that's the major the mode of transmission for the COVID-19. And for your question, regarding your question regarding the second wave, obviously this virus is still circulating somewhere in Japan, especially in Tokyo and some other places. And also we are still having some imported cases outside of Japan, and the locally transmitted cases and the imported cases that may trigger the larger outbreaks again. But we have a better monitoring system now, and we can also use new technologies, including the rapid test and the mobile app and some other technologies. And but we should become more we should be the more effective in detecting outbreaks, and by establishing such system, I believe that the outbreaks, the impact of the next outbreaks can be minimized.
A related question that's submitted in writing has to do with preparations for the Olympics next year. And I know it sounds like it's a long way away, but I'm sure it's something that you must be thinking about already. What kinds of steps are you thinking about doing to help to deal with the situation, streamlining, monitoring, testing, immigration control, particularly for the imported cases? And also, do you think this is a loaded political question, so you don't have to answer this last one, but do you think is it possible to have the Olympics absent of a vaccine?
For Olympic question, I've been saying the same thing. We are not fighting against this virus for Olympic. We are fighting against this virus for the human lives. So we have to minimize the transmission as much as possible, and but that's not for Olympic. And as a result, we may be able to have an Olympic, but if there are still ongoing outbreaks somewhere in the world, like the South American situation right now, we definitely cannot do the Olympic. So we have to collaborate with the many other countries to minimize the transmission of this virus.
how are we doing on time here? We have a little bit more time. Let me ask a question that a number of people have asked, which is your thoughts on where we are on a vaccine, development of a vaccine and therapies, and kind of what is Japan doing in that area? It's a big question, I realize, I apologize.
The number of clinical trials are being done. I'm not personally involved in the clinical trials, and it's getting very difficult for us to monitor all of these clinical trials and the development, the vaccine development, and so on. But I understand that there are we are getting some promising result, and I hope we can have the better situation in terms of the treatment. But the vaccine development is more the tricky one, and we need to have the safe and the effective vaccines, which may take more time, and also even if the vaccines are available in the next year, that doesn't mean that these problems can be solved in next year, because we have to vaccinate the many people in the world, which may take more time. So it's a long way to go, and we have to live together with this virus for some time, and we should be able to establish the better system to cope with this virus. Over to you.
Are there any major? I know that we see in the press a number of Japanese companies. Fujifilm is one that are developing therapies, and others that are developing vaccines. Do you see a promising therapy or vaccine being developed in Japan, particularly?
So the number of the pharmaceutical companies are involved in developing the drugs and the vaccines, and also the many researchers and clinicians that are involved in developing the pharmaceutical interventions, and also the clinical trials. And as I said, there are many things that are going on, and it's very difficult for me to monitor all of them.
We had a question about telemedicine. Obviously, this is, I know you're not a clinical practitioner at this stage, but I mean, are you seeing a takeoff in telemedicine in Japan as a result of this? And do you think it's going to stick around after we finally beat this virus?
So the many clinicians are now developing the new the system for telemedicine, and as you know, we are having the aging society, and the many elderly people are staying at home with many different chronic medical conditions. And in the past, the home care, the visiting homes, was getting common, but because of COVID-19, that may create the opportunity to transmit the virus to elderly. So in that kind of setting, telemedicine is they tried or they promoted, and also in many other the different the clinical setting, they are trying to they maximize the use of the telemedicine, and probably in coming months we may be able to develop the better system for the telemedicine.
Thanks. We have a couple of questions on testing. One is that you mentioned that early on there was a capacity constraint, which is not the case now. Do you think that, but you also indicated that that testing has its own problems because a lot of the super spreader activities are in health settings, which is an issue. But I guess one question was, if you did have, if you had adequate testing in February, March, or maybe March, would that have made a difference in terms of being able to get on top of this faster? In other words, well, yeah, that's the question.
But if especially in the situation is different right now, but in the February, March, and until mid-April, all positive cases should have been isolated in hospitals. Then if we test more cases, even the milder cases, they should be hospitalized. And at the end of February, end of March, the hospital capacity in some places, including Tokyo, was fully stretched. And if we identify the many mild cases and put them in the hospital for isolation, we might have been the very difficult situation in terms of the hospital care. And also we've been very cautious in expanding the PCR capacity because of the quality issue. The quality assurance is important. And also in 2009, the H1N1 pandemic, during H1N1 pandemic in 2009, we had the very congested the fever clinic. We set up the fever clinic in the different places of Japan. And the fever clinic was very, very congested. The people have to wait for the 3-4 hours, even 7 hours to be seen by the physician. And that kind of situation is the typical Sanmitsu 3Cs the situation. Especially in the February, March, it was very cold, still very cold, and the many people were waiting in the waiting area of the healthcare settings. The transmission might have been occurring, and we try to avoid such setting, and so we are very cautious in expanding the PCR capacity. What you?
Great, thanks. We have a question from Natalie Dean. Natalie?
Hi, thank you so much for this great presentation. I wanted to ask about the use of testing as part of cluster investigations. What do you think is the most effective way to use limited testing when investigating clusters?
For investigating the clusters, we use the PCR capacity, and most of the people in that the super spreading event setting were tested, and in some cases we could not identify all people in that particular setting, but the testing was used. Initially, as I mentioned, our PCR capacity was quite limited, but the testing was enough to test all the people in that cluster setting, and also the testing for most of the severe cases. So our PCR was prioritized for the cluster investigation and detecting the severe cases.
Thanks. We have another kind of related but technical question with regard to the testing and also to the kind of tracking, and that is in identifying the fact, or coming up with a number of 20% or 1 in 5 carriers transmit. How big was the sample that you used, and how did you determine the size of the N, the sample?
You mean what kind of people to be tested?
in terms of how the data that you, in order to come up with the analysis that 1 out of 5 carriers transmit to another individual, you must have done some kind of survey or taken data and then crunched it using a certain sample of people, right? And
yeah. So you mean to identify the finding, right?
right,
So,
and come up with a statistically significant correlation.
and the initial data was available from the cluster investigations during the very early stage of outbreaks, and so that data was analyzed by the Professor Nishura's group, and actually from the beginning, the public health nurses were doing a retrospective the contact tracing. Because in Japan, we are still having some TB cases, tuberculosis cases. For TB investigation, the identify the source of infection is very important. So the public health nurses were routinely have been doing this kind of the retrospective contact tracing routinely, and that's why in very early stage of outbreak, we managed to get enough the sample size to identify analyze the pattern of the infectivities, and now we have more cases, and we are still seeing the same pattern. And recently, our group they analyzed the data from the prefectures in Japan, and the pattern is almost exactly the same. And so we believe that this characteristics is the unique property of this the virus.
You mentioned actually, we had a very technical question as well, that TB, you just mentioned TB. There's a theory that BCG immunization might confer some resistance to COVID-19. Any views on that?
That's only the possibility, and we should explore any possibilities, and there might be some unidentified factors, and we are investigating all possible the factors, but the TB, I'm not sure that the BCG is a main factor, and so in Japan, most of people received the BCG, so it's very difficult to do any study in Japan. But in some other countries, some studies. I understand that some studies are going on, and we'd like to know their result as soon as possible.
Right. We have a number of questions about which I also share, which is when can we non-Japanese travel to Japan again? And this might be a question for Uyama-san. But is there any? I mean, what are some of the factors that you're looking at in terms of opening up travel?
Well, thank you very much for the question, and I think it's many people would like to know. And actually, there was a press conference made, and the same question was asked for Foreign Minister Motegi, and according to his response, there are a lot of considerations. We're looking at various cases, but still not decided concerning how we can open it and from where we can open it. So, at this stage, we don't have a definite answer for that. As you know, currently, as far as the Japanese Foreign Ministry is concerned, they give travel advice, and more than 100 countries, they rank the level 3, which means that they advise not to travel. And with regard to the same size of the countries, we stop the permission to enter into Japan. And but also there are certain sort of flexibilities in terms where there's compelling reasons for human considerations, and there's not very many, but there's certain cases could be considered on case-by-case basis. That's also being said by the Foreign Ministry. So that's only that's the only information I know. Thank you.
Great, thanks. Well, I know I speak for basically everyone here in the Bay Area that we want to get back to Japan as soon as we can, because we all, one of the things that Japan Society does, we all love Japan. This is the last question because we're out of time. But and I saved this one for last because it's a very lighthearted question, I think, and that is, what about the theory that's been viral on YouTube about korewa pendes, and in terms of that Japan has not had a major outbreak because of the Japanese language is softer, so that when you say korewa pendes, it's in English it comes out much harsher. So or pen. So what do you think about that particular theory?
As I said, we have to explore the possible explanations, and that kind of question is potentially the important, and we need to investigate any possibilities. And also in Japan, usually we are not hugging each other, and that kind of the lifestyle, the difference, the may explain the difference in terms of the epidemiological situation, and also the socialized pattern, the may be different between the Asian countries and the North America or European countries, and we also trying to investigate this possibility. And in general, the social contact pattern are quite different, and so that may explain the difference. And as I mentioned, there are many social and other factors that might be involved, and we are still having many unanswered questions for the COVID-19.
Great. Well, so I will be less dismissive of the korewa pendes theory going forward. So thank you for that answer.